Hello, I'm Dr. Michael Kahn, a physician with the Northwestern Regional Medical Group. I am one of the medical oncologists at the Warrenville Cancer Center, and today I'm going to be speaking about immunotherapy. So I also want to let you know that I will be referring to notes occasionally during this discussion because I don't have slides that will prompt me. So if I look down, that's the reason why. So I think the most important question that comes to mind here is, what is immunotherapy? Immunotherapy is a very generic term. It comes down to what does our body do to help treat and prevent cancers and other medical problems. I think it's also important to remember that immunotherapy is not chemotherapy. There's a very significant difference between the two. The most significant difference is that chemotherapy essentially attacks the nucleus and the DNA of the cells, including normal cells, but the immunotherapy is much more specific to attack mostly the cancer cells. Attack is generally not the right word, but it does work with the immune system in a way to attack the cancer cells. So the immune system is an incredibly complex system of cells, pathways, and chemicals known by many, many different names, which communicate and tell the body what is the non-self. So the system is designed to eliminate those things that are non-self and are in our body. Those include infected cells, sometimes cancer cells, and other cells that have sometimes mutated but are not necessarily cancer cells. During the day, there are about 20,000 mistakes that happen with our DNA, and our immune system helps to clean that up. It is also designed to remember those things that it comes into contact with in order to prevent further problems which are similar to those ones that it just affected. Sometimes the immune system will attack our normal self, and that is what we mean by autoimmune diseases. Those are things like lupus, rheumatoid arthritis, colitis, and other types of autoimmune diseases. There are several different types of immunotherapy which are currently being used on a widespread basis. For all practical purposes, I'm going to be very much limiting this talk to just several types of immune therapies, their mechanism of action, and some of the diseases that they are used against. Some of the treatments that we use with the immune system will stimulate the immune system to fight cancer, such as vaccine-based type of therapies, which are sometimes used for prostate cancer, as well as using other types of treatments that will make the immune system attack other parts of a cancer that we want to try to kill off. These things are sometimes called adaptive therapy. So some of these things that we also use to stimulate the immune system, like I said, could be vaccines. Sometimes in patients with bladder cancer, they will have a very early stage of bladder cancer, and we will put chemicals, and sometimes bacteria-type chemicals, into their bladder, which stimulates their immune system, and by doing that, the immune system will start and recruit other cells to come in and eliminate those cancers that are lining the inside of the bladder. I think the history of immunotherapy is really very interesting and will kind of give you an insight as to how these therapies developed. There's actually hieroglyphics from ancient Egypt which suggest that there was immunotherapy being used in ancient Egypt. However, it wasn't until the very early 1900s that it became officially recognized with an article in the New York Times when there was a doctor who was injecting bacteria into certain types of cancers, and after injecting that bacteria into the cancers, he would see that those tumors were starting to shrink away. Over time, after many experience and long research, some of them very futile, some of them very productive, it wasn't until 2011 that the first immunotherapy drug was approved for use in cancer. So I think part of this is also was knowing that there are several cancers that are known to regress spontaneously, and that's very rare. Those cancers include melanoma and renal cancer. And so there were some very inquisitive physicians who wanted to try to better understand that, and it was their assumption, and it was an excellent assumption, that it was the immune system that was causing these tumors to shrink away and disappear. And this led to a lot of research with multiple different types of immune therapies wherein patients would be infused with certain chemicals that would highly stimulate their immune system to make the immune cells kill the cancers. These treatments were successful and essentially provided proof of the principle that the immune system could be harnessed to fight cancers. So how does it do it? How does immunotherapy work? I think another way to help you better understand this is to remember that immunotherapy is also referred to as checkpoint inhibitor therapy. There are 16 different types of cancers now that are approved that we can use immunotherapy against. There are currently about 7 agents that are available that we know of, that we have, that have made it past the research phase, that are used right now to help treat these cancers. So the immunotherapy works by allowing the immune system to do really what it's designed to do. As I said before, there are multiple pathways that are known for the immune system and how it works. If I put up a chart and showed you all the different pathways, I think you'd be stunned. I can't even keep them all straight. I don't know anybody that can keep them all straight without having a lot of backup with these kinds of charts and working individually on a research project with these particular chemicals and knowing what these chemicals do. So it is the most complex and redundant system that I have ever come across. Like I said, it's designed for redundancy, but it also works to help us with our innate immune system as well as adaptive immunity. So I'm going to focus on the system where we have made the most progress. So there are some agents that will stimulate the immune system to work. Those things are used in some cancers, not regularly, but do have approval. One of them is a prostate cancer. It's a vaccine that is used. There are other types of research going on right now. There's also some use of something called CAR T therapy, where people's own immune cells, their T cells, are taken out of their body, juiced up and stimulated, and presented with the type of protein that's associated with that cancer. Those cells are then reinfused back into the body. Then the immune system does what it's supposed to do. It starts to kill off the cancers. But like I said, there's this particular type of therapy that I want you to be most aware of, which I think most people now consider immune therapy. It's the one that's advertised nearly all the time on television. It's this checkpoint inhibitor therapy. Right now, our T cells are designed to circulate through our body's blood vessels. And T cells are an integral component of our immune system. So they circulate through our blood vessels, they go out of the blood vessels, they go into the organs, they inspect the organs, and they inspect other tissues. If they happen to find a protein that's non-self, then they are programmed, basically, to kill those non-self cells. So how do they do that? These cells have little proteins on the outside of them, which the T cell, which has these things called T cell receptors on them, they can work like antenna and probes, and they attach to those receptors on these non-self cells. So when that happens, the receptor sends a signal to the inside of that T cell, which is carrying a poison with it, and it basically could kill those cells. So when they release those chemicals, they are basically killing the non-self cells. There are multiple different names for these T cell receptors, but the names really don't matter. It's the function that really is the most important part. Nature, it's brilliant. Nature decided that it had to balance these little killer probes that were on the T cell with certain types of proteins that could block the T cell from being able to cause the death of those other cells and not cause indiscriminate killing. So T cells also have certain proteins on the outside of them as well too, which are called PD-1. And PD-1 means programmed death. Programmed death is what it sounds like. These programmed death receptors basically tell the T cell, hey, this thing is self, don't listen to the receptor. Do not kill that cell. It is a regular cell. We want to keep it. So there's this kind of balance that's always going on between these receptors and these programmed death PD-1 receptors. Cancer cells, amazingly, have a lot of tissue on them that fake out those proteins that tell the T cells not to kill the cancer. It's amazing. So the cancers have a way of hiding themselves from our immune system. The immune system wants to kill the cancer, but it's being given a message, don't kill me, don't do it, just don't do it. The way that I have figured out to kind of explain this to the patients that I see in the office, and this is really going to date me, is that if you remember Star Trek, this is the kind of nerd, and then Klingons. The Klingons had these cloaks. People from Star Trek could not see those Klingon ships. And so what would happen is that Klingon ships could sometimes evade our friends in the Enterprise. And so that's what the cancer cells do. They evade our immune surveillance system. So what immune therapy really does is it makes those cells visible to our T cells. The immune therapy really are antibodies that block those PD-1 receptors on the T cells and the link that they have on the cancer cells. The cancer cells have that link that the PD-1 attaches to, and that's called PD-L1. Why it's called that, quite honestly, is irrelevant right now, but that's what it does. So they have these, like I say, there's about 7 different of these immunotherapy drugs out there right now. So many of them will block that PD-1, others block that PD-L protein. So you have different ways of fighting off, letting the immune system fight off the cancer. Something very similar that works is something called the CTLA-4. The CTLA-4 was the first protein the drug that was first brought to market that was used to use the immune system to fight the cancer. Again, it does it with a different name, but the process is somewhat the same. Again, the redundancy is incredible. The number of things that are going on are incredible. So CTLA-4 was initially used, and it was initially used in melanoma. And that's why right now there's been so much improvement in the outcome for patients with melanoma when we can use some of these anti-CTLA-4 antibodies, as well as combining them with other immunotherapy drugs. So, it really sounds miraculous, and it is. It's really an incredible change in what has happened in terms of oncology management. The very disappointing thing, though, is it's so complicated that we don't know all that we would like to know. And yet, we still have cancers that are not sensitive to immune therapies. I treat patients with prostate cancer frequently. Unfortunately, most of the research going on right now has not shown us that these immune therapies are all that successful against prostate cancer cells. I think that with time, as there's more bench research going on, we are going to find these little magic locks and keys that are going to allow us to have the very favorable outcome. So the immunotherapy is used in many other different types of cancers. It's used in other urologic cancers, meaning like bladder cancer and kidney cancers. It's also used in lung cancer, head and neck cancer, gastrointestinal cancers, triple-negative breast cancers, and other different types of cancers. So we have these really amazing biotech chemicals that we can use to help fight cancers. So the question became, well, can we combine them with chemotherapy? And the answer is yes. There are regimens where we do combine chemotherapy with these immune therapy drugs, which has shown significant success in terms of helping to put the disease into remission. However, I think there's a couple other caveats I think that are worth noting. Again, immunotherapy is not the same as chemotherapy. They are completely different mechanisms of action. And again, it doesn't work for all cancers. One way or another, we're going to figure out these pathways. I know it. It's going to happen. In my lifetime and in my career, I would have never expected to have seen this kind of advancement in cancer management. And I say that because there's some patients that I have treated with immune therapy who have had remarkable outcomes. Patients with severely advanced disease came to me with stage 4 disease, who I am not having to treat right now for their cancer because their immune system has been taught to memorize and recognize those cancers, and the cancer just isn't growing back. That doesn't happen with all patients, but it can happen. So the question becomes one of how long do patients get treated with immunotherapy? In general, there's no right answer. You keep treating as long as it's successful, or up to 2 years, depending on the type of cancer that it is. I think it's also important to realize as well, too, that immunotherapy doesn't work super fast. We don't do CT scans immediately after somebody starts their immunotherapy. When you think about it, there's a good reason for it. The immune system is stimulated to attack the cancer cells. When it attacks the cancer cells, it can cause swelling of those sites that we already know are disease. It may also show sites that we had no clue that there was disease. There may have been some microscopic disease in those spaces, but our scans just weren't sensitive to pick that up. And that includes PET scans as well, too. So after somebody gets their immunotherapy, there's going to be some reaction from the cancer itself. If we do a scan too early, we're going to get faked out. I want to give an example of one of my patients. This was a patient of mine with bladder cancer who had very extensive disease when I first met her. She had a lot of disease in her lung as well. She had just gotten maybe about 2 months or so worth of her immunotherapy. She went into the hospital for something different, a scan was done, and it looked like the cancer had gotten significantly worse. Remember though, that scans really are shadows. We are just making shadows with scans, and we are interpreting those shadows. Radiologists might not be so happy I was saying that, but they have a very sophisticated way sometimes of telling if those shadows are more metabolically active or not, or if they're more suspicious. But for the most part, they really are shadows. So this patient, she had disease that had really swelled up a lot because of her immunotherapy. She was in the hospital for something completely different. There was nothing going on to make me think that the cancer was any worse. So we continued with her therapy. And after 4 months, we really did not see any more lesions on her. And so that was very favorable, obviously. But that's always hard to predict who that might happen to. That's called pseudoprogression. And there's always some debate about the issue with pseudoprogression. Is that real or not? Most of the studies that are done now, patients are treated for about 4 months with chemotherapy, and then they are scanned to get a good assessment of what may or may not be happening with their disease. So, I also think one of the things that has to be kept in mind is that we are learning a lot as time goes on about these therapies. Because these therapies let the immune system become very active, there was always concern, and rightfully so, that people with autoimmune diseases should absolutely not be getting these immunotherapies. Well, the feeling on that is starting to change. But that's because when they looked at some of the studies that were done with patients that had autoimmune diseases and that did get treatment with their immunotherapy, they can't say that things necessarily got worse because of their underlying autoimmune disease, that it necessarily flared severely. That's not to say that immunotherapy doesn't have serious side effects that we need to be aware of. It does. It has potentially fatal side effects. The most common side effect, however, involves the skin, which is usually like a rash or hives or something of that nature. But sometimes it can cause something that I call the itises, like colitis, which is inflammation of the bowel, pneumonitis, which is inflammation of the lung, thyroiditis, which is again inflammation of the thyroid, cerebritis, inflammation of the brain, myocarditis, inflammation of the heart. Those are not as common. However, I want to talk about a patient of mine that I just saw in the office last week. This was a patient who came to me with very advanced kidney cancer. She enrolled in one of our trials. It was a dual agent of immunotherapy. And like I said, when you think about dual agent, you're likely to get a brisker immune response. One of the things that happened to her was it made her immune system so out of balance that her immune system started attacking her other kidney. And her kidney function became wildly abnormal. However, over time, she did recover. She is on dialysis. The cancer that she had in her body was not as obvious. She was taken to surgery, and when she was taken to surgery several months ago, all of the stuff that looked like it could be cancer, it was all dead tissue. She's actually doing very well right now. Unfortunately, because of her immune attack from her immunotherapy, she ended up needing high doses of steroids to decrease that immune response. By doing that, the steroids cause other complications as well. So, as gentle as immunotherapy sounds, when it sounds like you're going to be using your own immune system, it can cause serious problems. And I think that's a really important thing to keep in mind. But I want to end it on a positive note. Another patient that I saw last week, she had come to me with lung cancer, metastatic lung cancer. She had brain metastasis, metastasis to her bone, metastasis to her kidneys. We stopped her therapy several years ago. There's no evidence of disease. She was treated with immunotherapy, no evidence of disease. Another patient of mine who had very advanced metastatic colon cancer, I have not treated her for several years, easily. with immunotherapy, living a completely normal life. So it's an amazing, amazing advancement, something that I am so hopeful for, that we will be able to harness and gain the knowledge that we need in order to treat other cancers that we have not been able to take care of with this type of therapy. Because it's our body that wants to take care of this cancer. So I'm going to end it at that. I think there's maybe some questions, so I'll just off-site here, wait for some of those questions.
Yes, I do have a question right off the bat, and that is, how is immunotherapy given? Is it like chemotherapy if you go into an infusion room? How does that work?
Yeah, it's generally given intravenously. Infusion can take about 30 to 40 minutes. It just depends on what the agent is. It's typically given once every several weeks. Thank you for asking that question. I forgot to mention that in my talk. So that is how it's done. Yeah.
Another question came in. Janelle is asking, do you have any success stories with kidney cancer?
Oh, yeah, definitely. I think that woman that I talked about, I have another patient, a man, who came to me with metastatic kidney cancer. He had metastatic disease in his lung. The disease in his lung disappeared with his immunotherapy. He went to surgery, had the diseased kidney removed, and the other lymph nodes around it removed. I see him now about once every 4 months. He is working and living a completely normal life. I think that's successful, you know.
I would too, yeah. Another question for you. Is any preparation needed for immunotherapy on the patient's behalf?
Just optimism. Not anything clinically that I can think of off the top of my head. But if you're using any kind of immune suppressive drugs, like steroids or transplant rejection drugs, then the doctor does need to know about that.
Okay, so will immunotherapy interact with any over-the-counter drugs like Tylenol or any vitamins, or is there anything you need to not take before?
Not that I'm aware of. Not that I'm aware of.
Another question, any success stories with prostate cancer? Nice.
Yeah, not so much. I mean, there's a lot of research going on in prostate cancer with immunotherapy. Hasn't been as successful as some of the other cancers that have shown the kind of success that we've seen, but they're definitely working on it, but not as much as we would like to see.
Last question, I think, here. Oh, maybe not. Another question, what about GBM brain cancer? Any success stories with GBM brain cancer?
I honestly don't know the answer to that because I don't treat that very often, if at all. I just don't know the answer. I know they use monoclonal antibodies in it, but I don't know how much of it, how much is immunotherapy. I just don't know the answer to that. What I can tell you, though, regarding that is there have been some studies which is based on immune-based principles where they were injecting virus-like particles into the tumor, and that would induce an immune response with the tumor. That would change the tumor and sometimes induce a systemic immune response, and the body sometimes would go after the tumor that way. But otherwise, I just couldn't say much about GBMs. I just couldn't.
Do you have any experience with CLL? Any success stories with CLL?
As immune therapy for CLL?
Yeah.
I'm trying to think. I had a lot of CLL patients, but not off the top of my head that I can think of. CLL is not one that is typically treated frequently with immune therapy, is to the best of my recollection.
Okay. Let's see. How about, will other treatments like radiation and chemotherapy be used at the same time with immunotherapy? Are they typically
Yes.
used in tandem?
Yes, they are. There are regimens where the chemotherapy and the immunotherapy are combined together. That's especially common in lung cancer. It's done like that. What they have found with radiation therapy is that sometimes the radiation and the immunotherapy together, they potentiate each other. They get even a better overall response than they otherwise might. Can't say necessarily that that is considered the standard of care right now, but as it is with lung cancer. Certainly it is. I know that with breast cancer, women with triple negative breast cancer, a very specific type of breast cancer, a higher risk breast cancer, they will combine chemotherapy and immunotherapy prior to the patient going to surgery, and that has been shown to be more effective than just the chemotherapy alone.
Someone is asking, what is Venetoclax?
Venetoclax?
Venetoclax, there we go.
I'm not going to answer that. I don't know right now.
Okay.
For what? I mean, it's used for other things, so.
Yeah, the question that came in from Fran was, what is it? So,
Yeah.
so Fran,
Yeah, no, it's used for other kinds. It's used for lymphoid or hematologic kind of malignancies.
someone is asking, had you had any success with immunotherapy and cholangiocarcinoma?
I don't treat cholangiocarcinoma. I don't know if there's a lot of data out there about it. I just can't answer that question. I generally treat a lot of the GU oncology, which means the bladder, the kidney, testicular, prostate. So basically, like I said, a lot of the information from immunotherapy got its start with the renal cancers and the bladder cancers. So that's my area. I just don't treat cholangiocarcinoma very frequently.
I think this is the last question. If immunotherapy, if someone is doing well on it and all the, the cancer after several years comes back, would you treat again with immunotherapy? Can you do it twice or
Yes,
however
you could.
times?
You
Okay.
could. Yeah,
Okay.
you could. Yes.
That is all we have.
That's it.
Thank you so
All
much.
right. Thank you. Thank you.